Hi, I'm Heather McCormack, and I'm presenting findings from a qualitative project titled Integrating Testing for Sexually Transmissible Infections into Routine Primary Care for Aboriginal Australians. The interview data we analysed for this project was collected as part of BREEZE ASP in 2016. This was an Aboriginal-specific stream of BREEZE, which is a New South Wales Health-funded consortium for policy-relevant research. The original research team interviewed senior staff who were based in either one of 6 Aboriginal community-controlled health services or one of 5 government local health districts that were involved in supporting those 6 Aboriginal community-controlled health services. And from here on in, I'll refer to Aboriginal community-controlled health services as ARCHIS and local health districts as LHDs. The transcripts were originally analysed for a brief report with a focus on identifying strategies that had led to an increase in STI and BBV testing and treatment. We completed the secondary analysis that I'm discussing today to generate more in-depth understanding of the insights from this hard-to-access group of experts regarding the specific question of how to integrate STI testing into routine care. The objectives of this analysis were 1, to identify factors that enable successful incorporation of testing for STIs in routine care for Aboriginal people in New South Wales, and 2, to analyse how staff of local health districts and Aboriginal community-controlled health services understand these factors. The interview transcripts underwent a strengths-based thematic analysis using the model outlined by Brown and Clark to systematically identify and organise patterns of meaning in the interview data. An important feature of this analysis was that we explicitly adopted a strengths-based approach from the beginning. The Lowicher Institute describes deficit discourse as discussions about disadvantage that narratively frame Aboriginal people as inherently deficient and problematic. It makes the problem Aboriginal people rather than systemic factors like racism. Deficit discourse is prevalent in health research and policy, and an epidemiological framing that is deficit-focused can reinforce deficit discourse in the programs and services that are meant to address health disparities. We explicitly acknowledged our intention to get past deficit discourse and adopt a strengths-based approach, and we actively centred the strengths, assets, and capabilities of ARCHIS and ARCHIS staff throughout our analysis. The sample consisted of senior ARCHIS and LHD staff from across New South Wales, representing 6 ARCHIS and 5 LHDs. You can see the range of participant roles on this slide. The original project team sampled purposively to ensure representation of different Aboriginal populations and diversity of ARCHIS. All participants had experience in delivery of STI and BVV programs for Aboriginal communities in New South Wales. And the ARCHIS selected included regional, remote and metropolitan ARCHIS, as well as both ARCHIS who had and had not received STI and BBV funding from the New South Wales Ministry of Health. Only LHDs that provided services to the same geographical region as a participating ARCHIS were invited to participate, and both Aboriginal and non-Aboriginal key informants participated in interviews, as well as both men and women. The researcher who conducted the original interviews is also a co-author of the secondary analysis. We completed a thematic analysis and developed this thematic map of themes and subthemes. The 4 items highlighted in white on the thematic map are the dominant themes related to STI testing in routine care. So these are improved patient experience, standardised test sets, the MBS 715 as a best practice lever, and the holism of community control. I'll discuss these themes in more detail on the following slides. All the interview data that focused on the integration of STIs into routine practice represented this as a valuable goal. Embedding STIs into routine care was seen as a way to reduce the shame and embarrassment associated with discussing sexual matters, particularly for young people. It was seen as a way to protect the privacy and confidentiality of patients accessing sexual health care, with some participants noting that this was a particularly important issue in small Aboriginal communities where patients are likely to be well known to ARCHIS staff. It was also seen as an effective strategy to reduce stigma associated with sexual health, with several participants recommending linking STI testing to other routine tests which are less stigmatised, such as blood pressure or blood sugar, as can be seen in this quote from one. It's not, we're picking on you because we think you look a bit dodgy sort of thing. Thinking you look like you need testing. Getting it so it's a norm. We test everyone just like we'll do your blood pressure and your blood sugar. Then we want to test for STIs because that's a normal thing. Another perceived benefit of making STIs part of routine care was the capture of asymptomatic cases who present to ARCHIS for reasons other than sexual health care. Generally, participants felt that the inclusion of STI tests in routine medical consultations that had been organised for other purposes was relatively frictionless for patients, and it facilitated much higher testing rates than relying on patients to request an STI test. One of the strongest recommendations across the dataset was the use of standardised test sets for comprehensive STI tests, so inclusive of chlamydia, gonorrhea, syphilis, HIV, and trichomoniasis where appropriate, that are offered as part of routine health consultations. This was perceived as an ideal strategy for avoiding the stigma and bias that can be associated with risk-based assessment, while still capturing individuals who are at higher risk. From the provider perspective, the use of standardised test sets was believed to improve consistency of services. Participants explained that terminology used to request sexual health screening varied between clinicians, and pathology requests for STI tests may not be inclusive of all major STIs unless the specific language recognised by the pathology lab is used. The importance of standardising test sets is seen in this quote. If someone just puts in STI testing, they might not get everything. One thing we did, and we've had good success at getting all the tests that we need, is completely rewriting and trying to encourage GPs not to use certain naming conventions, but to use the ones we've devised so that we get exactly what we ask for. In particular, some participants recommended taking a systemic approach to standardization by using technological solutions such as auto-populating pathology requests via the patient management system. Related to the previous theme, several participants mentioned the Medicare Benefits Scheme item number 715, Aboriginal and Torres Strait Islander People's Health Assessment, and from here on in, I'll just refer to this as the 715. Some participants also refer to it more generically in their quotes as a health assessment or a health check. The 715 is an incentivised annual health screen for Aboriginal people, with sexual health screening recommended for inclusion for people aged between 15 and 29. And our participants saw it as an ideal lever for embedding an annual STI screen using standardised test sets into routine healthcare. This quote shows that participants viewed it as having benefits to both the provider and the patient. Just a conversation that the nurses and I had because we were looking at our STI screening data and we thought we can do better. And we thought, what sort of activities? How can we do things differently to increase the uptake of screening? And it was obvious to all of us the best way to do it is when you're doing the Aboriginal health assessment. You make it the norm. Start to break down the barriers. Making comprehensive STI screening a routine part of every annual MBS 715 delivered within an ARCHIS lifted testing rates across the service and contributed to increased performance against STI testing KPIs. Several participants highlighted the holistic approach taken by ARCHIS as a strength. Specifically, participants felt that the incorporation of preventive healthcare and health promotion into comprehensive health assessments like the 715 were benefits of sexual healthcare in ARCHIS that were not as likely to be provided in mainstream general practice. Holistic care was also emphasised in the context of collaboration between ARCHIS staff from different disciplines. Several participants identified collaboration between doctors, nurses, and Aboriginal health practitioners in the delivery of the 715 as a common feature of high-performing ARCHIS, as can be seen in this quote. So this service has a nurse doing pre-work, passes that on to the GP. There's a clear delineation of what people do, and they look at people holistically. People are getting really good overall preventative healthcare, and sexual health fits into that. So it's just become such a routine practice in that service. There was a shared assumption that treating STIs as equivalent to other aspects of routine healthcare contributed to the successes of these high-performing services. Our participants strongly supported integrating STIs into routine care for Aboriginal people in New South Wales to improve sexual health. This analysis supported several key findings from previous research, such as that offering STI testing to all young people attending a service as part of routine healthcare helps bypass shame and stigma that can act as a barrier to testing. Systematic efforts to normalise STI testing within services increased acceptability and uptake. Our participants recommended use of standardised STI test sets within the 715 as a best practice strategy for integrating STIs into routine care within the ARCHIS setting. Thanks for your time.